And
I apologize. I have a cold, so I have to
It's okay.
drink here.
okay, I'm going to start the recording. And you can begin at any time.
All right. Well, hello, everybody, and welcome to this block session of Physician Pathways. My host, Mariah, and I are happy to welcome Dr. Jennifer Palagiri to our show. Dr. Palagiri truly bleeds SLU blue, studying at SLU for medical school and completing both her residency and internal medicine fellowship in gastroenterology here at SLU. Dr. Palagiri, currently serves as an assistant professor of internal medicine at SLU in the Division of Gastroenterology. And she also serves as the GI Fellowship Program Director and the course director for the GI module for the SLU M2s. So Dr. Palagiri, welcome to the show.
Oh, thank you for having me today. Appreciate the invitation.
Sure. Dr. Palagiri, just to get us started, as an introduction to maybe some of the students who, some of the M1s who haven't had a chance to have your block yet, could you just give us a quick one-liner about gastroenterology, just kind of what it entails in practice?
Sure. So we take care of the patient with any problems with their entire gastrointestinal tract, from the mouth to the rear end, including all the glands in between, such as the liver, pancreas, and biliary. From tummy aches to liver disease and colon cancer screening.
That's very nice. Well, one thing we feel like a lot of medical students want to know about specialties is scheduling. So how do you feel like the residency schedule is like for GI versus other specialties, or just how you felt like it was for you?
Great. That's a great question. So in order to do GI fellowship, first you need to do internal medicine residency. Of course, that residency is 3 years. It's a great residency because it opens up a lot of doors if you're not exactly sure. If you think you may want to subspecialize, but you don't know for sure, that is a very good thing. And you can also practice as an internist and be very fulfilled. But so that is 3 years. And then the GI fellowship is 3 years after that. So it would be 6 years of postgraduate training, which seems a little bit daunting, but really it's not. I mean, you're going to do a residency that's on average 3-4 years anyway. And then if you like GI, you're really doing what you like to do. And fellowship is a lot better in terms of schedule and responsibilities compared to residency. And so it does get better with each stage. So don't let the 6 years of postgraduate training scare you away.
Yeah, we had a student question about this, Dr. Palagiri. So, I had brought this up before we started this interview today. GI is one of those subspecialties that it seems like you can subspecialize even further. So could you talk about some of the options for, further training after you finish your fellowship? And then can you talk a little bit about why students would or would not decide to pursue that route?
Yeah, that's a great question. If you think about it, the GI tract actually contains many different organs. And so you can subspecialize quite a bit through that. So fellowship is 3 years. After that, you can practice as a general GI physician. You can see patients with liver disease. You can do general endoscopies, but there are several subspecialties beyond that. One of the most common ones that our GI fellows pursue after training here is advanced endoscopy fellowship. So someone who wants to do more biliary endoscopy procedures. For those of you that have already had the GI course, you know about ERCPs and treating patients with gallstones, stones that are stuck in the bile ducts. That's one thing that you can learn as an advanced endoscopist. Also endoscopic ultrasound, in which you can diagnose pancreatic and liver tumors, and do other advanced procedures such as placing esophageal stents, draining pancreatic abscesses endoscopically through the stomach wall, for example. So there's a lot of advanced procedures that aren't taught in general GI fellowship. Also, you can specialize in inflammatory bowel disease. There is so much new information that has come out for inflammatory bowel disease over the last 15, 20 years in terms of medications, how we treat the disease, that it has become very subspecialized. And so there is an advanced fellowship in IBD as well for those who are interested. You can subspecialize in motility also. So if you have a strong interest in esophageal and gastric motility disorders, for example, there's a large niche for that as well. Likewise, if you want to do transplant hepatology, you want to be at a large academic liver center that does liver transplant, that's a separate fellowship as well. So you do another year learning how to take care of pre and post-transplant liver patients. The general GI fellowship includes a nice, well-rounded curriculum for hepatology, but if you want to do transplant, it's a little bit more focused. And so that is a separate fellowship as well. So yeah, lots of different opportunities within general GI.
Yeah, that sounds like someone who is indecisive should not go try looking any further. But for someone who's just like a regular GI doc, what are the most common procedures or patients? Like, what's the group's bread and butter, would you say?
Great. So lots of fun things. Every day is different. So obviously a large portion of the procedures are screening colonoscopies, also upper endoscopies for a indication of heartburn, difficulty swallowing. We do a lot of those, whether you're in private practice or at an academic center. We also place feeding tubes in patients who can't swallow. We can place a feeding tube endoscopically that goes through the abdominal wall into the stomach and bypasses the oral pathway of eating. So someone who's had a stroke, for example. Those are the major, most common things we do. We have special scopes that look into the small bowel. We can do and interpret motility studies if we suspect someone has achalasia, and we can do an esophageal function test, which is an endoscopy, but the test that looks at how well the esophageal muscles function. So there's a lot of it. It's usually a mix of doing procedures in the endoscopy suite as well as seeing patients in clinic. So patients who have GI symptoms or may have a GI diagnosis of hepatitis C or autoimmune hepatitis or Crohn's disease or even irritable bowel syndrome a lot.
It sounds like the practice is pretty extensive, Dr. Palagiri. One thing that we like to ask about is how practice changes depending on setting. I guess that would be private practice versus an academic setting, and then like a rural setting versus a more urban setting. Is practice of GI pretty consistent across the board, or does it differ depending on where you are?
Great, that's a great question. And so part of the endoscopic procedures, the menu of endoscopic procedures you can do, I suppose, depends a little bit on where you are. Here at SLU, for example, we're a large academic center, and we have great surgical backup. So, for example, we may do something and it may be a risky procedure, or we may be attempting to stop a bleeder and we can't do it, but we have great access to interventional radiology. And we know that we can attempt to do our treatment endoscopically, but if we can't, we know we've got great endoscopic backup. So we can be pretty advanced in terms of our endoscopy procedures that we do. If you have a liver patient who's bleeding profusely from esophageal varices, we feel confident in treating that, and we know if we can't, we've got our interventional radiologist right here who can be as our kind of right hand backup in case we can't stop the bleeding. We can treat achalasia, for example, with pneumatic balloon dilation. So that has a great risk of causing an esophageal perforation. So we will only do that procedure when we know we have a cardiothoracic surgeon in-house as our backup, just in case we cause a perforation during the procedure. So large academic centers, you can do a lot of cool endoscopic things just because we work together very closely with our other services, surgery and interventional radiology. You still see, even if you're in private practice and even in a rural private practice, still see a lot of very interesting things. You just have to think about what your capabilities are at your hospital. So someone who is in a rural private practice, maybe at an outlying hospital that's a little bit smaller, they may not take care of as complex patients as others. She's talking to a friend of mine the other day, and she practices at a small hospital where they don't do inpatient dialysis. So, if someone is sick enough, say they have liver disease that's causing renal failure, then those patients need to be sent to an outlying hospital. in private practice as well. It's people think, oh, I'm just going to be in private practice and do screening colonoscopies all day, and that is definitely not the case. There's certainly a lot of GI pathology out there, GI symptoms out there in the community. So everyone sees a pretty good mix, for sure.
Well, just kind of speaking of the community, do you feel like your patients, do you build any continuity with them? Because I know some of these, like the cancer ones, you might see more often, but is GI kind of more like you fix it and then you don't really see them until something else happens, or do you stay in touch with patients?
That's a great question. Actually, we do have quite a bit of continuity. Sometimes it's something simple. Patient comes in with heartburn, we start them on a medication, they feel better, and then we can refer them back to their primary care physician, and then the PCP can manage it from there. For our inflammatory bowel disease patients that we have on immunosuppression, we follow them regularly. That's a very rewarding part to the practice. A lot of these patients are young, maybe they're in high school, entering college, and so these are people that you have and you follow for a long time. Likewise, people who have other diagnoses such as hepatitis B that you need to monitor over time. Hepatitis C, where you treat them and you cure them, you don't need to see them back. And then they're also, you do these screening colonoscopies on folks, and periodically we'll find a surprise cancer in someone, and that becomes a relationship that you may not necessarily see them in clinic, but you tend to kind of follow them up. And then when they're ready to come back for their 1-year follow-up, they'll call you up and say, hey, I've had my surgery, I've had my chemotherapy, I need to come back for my follow-up colonoscopy. Will you do it? And I've had a few of those patients, and it's been very rewarding to follow them over the years and see how they're doing. So it is a nice mix. We try actually some of the non-complicated patients, we try to see them and get them back to their primary providers. But a lot of times they'll end up coming back just because it's, especially with an irritable bowel syndrome patient that has a lot of debilitating symptoms, they like to come in and get that reassurance from their GI doc. So we have a lot of chronic patients.
This next question is coming from a student. So the student was wondering how you think that your work-life balance compares to some other specialties.
Sure, that's a great question. The nice thing about GI is there are a lot of different practices that do things different ways. So you can pretty much carve out how you want to live. There's pros and cons. So it's a mix of clinic, hospital care, and procedures. So if you don't like having to follow patients longitudinally, then clinic is probably not for you. You're checking labs, you're checking imaging results and following up and then touching base with patients again. So there's that aspect of it. There are emergency procedures. So we always have to have someone on call. If someone has a food impaction, if someone has swallowed a razor blade, we get, a lot of different things. Someone who's bleeding profusely and is unstable. Those are procedures that need to be done in the middle of the night if that's when they roll in. And so there is call associated with it, of course. So it's a good balance. We're at a large academic institution where we have 12 of us, and so we share call. We're on call like once every 12 to 13 weeks, so it's not too bad. We work with fellows, so the poor fellows get a lot of the phone calls before we get involved. But we do come in when there are procedures, and we do round on the weekend. But there are other practices that have things arranged differently. So you could be just a GI hospitalist, where you come on and you do GI consults and inpatient scopes for a week on, and then you're a week off and you don't do any clinic. Other practices have it arranged where you are the consult person for the hospital for the week, and you're just in the hospital working, doing scopes and doing inpatient consults, and you don't do any clinic. So that when you are not on call, all you have to do is clinic, and it's an outpatient scopes. So there's really the gamut of different types of practices. I think over the years, many practices have become a lot more open to accommodating folks who want some good work-life balance. I'm a prime example of that. When I finished the fellowship, I came on and joined faculty full-time, and then about 5 years in, my husband and I had our son, and I decided I really wanted to step back. My husband's a busy physician too, and so it was just very busy. And so I stepped way back part-time and was only 0.3 FTE, so I was about 30% of full-time. So my job was just doing 1 day of scopes and a half day of clinic every week, and so it was really nice. And then I took call also, but that was a really nice balance. And now that he's a little older, I'm back doing more, enjoying it. But yeah, so there's a lot of opportunity to kind of carve out the special schedule that you want, which is nice.
Yeah, that does sound really good. But I'm sure one thing as students are kind of wondering is what's GI gonna look like when we are attendings or fellows? So like, where's the specialty heading? Do you see any things becoming more prominent or less prominent?
Great question. So we were all worried a few years ago, 10 years ago, when CT colonography was coming out, which was the way to do CT scans for screening for colon cancer, and we thought colonoscopy was going to become obsolete, and that has not been the case. We're concerned that there's going to be a GI shortage actually in the next decade, and so that is a concern. We have, especially in academic GI for sure, but in private practice as well. As technology has advanced, there is a lot more room to do more endoscopic procedures of various different kinds and more subspecialization. Also with treatment of inflammatory bowel disease, that's kind of the two big technology changing fields, I would say. So there's definitely more. As it becomes more complex, I think people will subspecialize more. You would think, it always amazes me just here in St. Louis, for example, we graduate 4 fellows every year. Washington University graduates 4 fellows every year. And if people want to stay in St. Louis, there's plenty of GI jobs here just within the city. There's a lot of GI pathology out there, a lot of anxiety as well, and a lot of the psychosocial problems that patients have also manifest through GI symptoms frequently. And so there are also a lot of patients out there that have significant GI symptoms that may or may not be related to psychosocial issues, but they have very significant symptoms. And so we see a lot of patients with that. And I think that cohort of patients will only continue to grow, actually. Question.
What are some challenges that are facing your specialty currently?
Sure, good question. So I think most physicians would answer this. Always, insurance coverage and reimbursement. So, especially some of the medications we use are very expensive, especially inflammatory bowel disease and biologic medications. And so having a good resource to navigate the insurance requirements and these prior authorizations. Our practice is very lucky in that we have a pharmacy concierge specialist who helps us do prior authorizations and really get the ball rolling on those medications. And so that's very important when you're choosing places to work, to have that kind of support staff to do those types of things. And just making sure that you know how to code things appropriately so that patients get their care covered. But in addition to that, there's just having patients have access to care is always a challenge, not just limited to GI for sure. And thinking about medications that we prescribe and the cost to patients is a very big deal. Of course, COVID has been a challenge as well. The last few years, we've been able to expand and at least really ramp up our video visits with patients, for example, to increase access, but it's not quite the same. And so certainly some patients have missed out on care that they might have had otherwise had we had better access during that time. Biggest challenge.
Well, on a little lighter note, hopefully, have you noticed any stereotypes in terms of the people who go through GI residency or fellowship?
Well, I think everyone's very down to earth. You just have to have a good personality that's pretty laid back, I guess I would say, because patients are coming in and they're talking about things that they may not talk about with their family members or may not feel comfortable talking about with anyone else. And so we all try to make them feel comfortable. It's not easy to come in and tell someone you've never met, well, I'm having incontinence, of diarrhea. And so we really need to just let patients feel comfortable. We're serious, but yet we don't take ourselves too seriously. So I think you always wonder, is it the science that attracts you to a specialty, or is it the people in the specialty that attracts you to it? And I think definitely that personality kind of perseveres through GI. People are pretty friendly and happy people, I think. We'll see, but yeah, for sure.
All right, well, thanks for that, Dr. Palagiri. We're going to switch gears and ask some questions more about you specifically.
Oh, sure.
So what drew you to GI?
That's a good question. A few things. For me, I think it was probably the people, for one thing. I went into residency thinking I was just going to be, that I was going to do general primary care and do outpatient internal medicine. And then in my intern year, I rotated on the liver service, and I thought the liver attending was really funny, and just had a good attitude towards medicine. And so I started doing a couple more rotations of GI, and then I realized that, I really like being able to do procedures with my hands, and then also taking care of patients in clinic and being able to provide both. And I knew I didn't like surgery. Thought, well, these are procedures that we can do. We don't have to be sterile. We don't have to do rounds in the morning and take down everyone's wounds and then dress them back up again, which is kind of a lot. So yeah, the GI procedures are nice and quick. They're very straightforward. And so I did like that aspect. And again, just kind of getting people to open up to you and express their vulnerabilities to you, and getting to know patients on a level that you don't always get to know them has been very rewarding. That's part of it, I think.
So you mentioned like really enjoying your GI rotations. Were you deciding between two or more specialties, or was GI just kind of your all in?
It was all in for that. I think a little bit I thought about critical care. And it's funny because some of my colleagues have made the same comments in the past. So that I was thinking about as well a little bit, but I also liked the outpatient aspect too. So, and I knew with that I wouldn't have that.
What's your favorite part about your job, Dr. Palagiri?
Ooh, for me, it's the teaching. I like working with the fellows, the residents, the students. So I still do all the clinical stuff, and I do like that, but I do like working with the students, working with the fellows. It's just really fun to teach them and round with them and do procedures with them, and just kind of share that aspect of it. I like. It's social, it's educational, and that part I do like a lot.
And I think we have to follow up with this question. What's like your least favorite part? What's the hardest part of your job?
The hardest part is when we find a colon cancer on a patient who just comes in with their screening colonoscopy. That's always very awkward. Just because, here the patient has come in and now they've just had sedation, they've had a procedure, and you need to go explain to them what's happened. If they don't have family with them, it's always very difficult. So that's probably the part that's the least fun, for sure. But it's important. So, colonoscopy is a very important part of what we do in colon cancer screening. And so at least we feel like, okay, at least now you know what's going on and we can deal with this and move forward.
So for an M2 about to be M3 going on to their internal medicine rotation, how would someone interested in GI be able to select that as an elective? Because I feel like a lot of us M2s haven't been told that process.
Good question. So let me, so who is it? Madeline Rowe who helps you with your electives? Is that a name that sounds familiar?
Yeah, I don't think we've been introduced to that yet, so I'm not quite sure.
Okay, so there is a person who helps organize the electives, and then they get sent to our program coordinator, and her name is Laura Robinson. I'll put it in here. She's the GI Laura Robinson, because I think there's another one. So she's our coordinator, and she works with Madeline in the medical school to coordinate rotations. So there are different services you can rotate through as an M3. It can be the inpatient liver service. That is the only primary inpatient service we have. The GI service is all consult, but certainly, and then you can also do clinic if you were doing an outpatient one as well. So I think, and I don't know if Madeline just does M3 or M4. I'm putting her name into. Not sure how to spell it. She's the other one who helps coordinate the rotations for us. So yeah, so if you're interested, that's a good time to do it. Also, as you move into 4th year and do electives, there are lots of opportunities, outpatient, inpatient consults. You can do a 2-week or 4-week elective. You could do a 4-week elective and then mix it up like 2 weeks of inpatient consults and 2 weeks of outpatient clinic. You can hang out in endoscopy, lots of different things to do.
Those sound like some great opportunities. So Dr. Palagiri, for the like the M2s and even the M1s that are on the call here, what are some things that are good to get involved with to be competitive for a GI fellowship down the road?
Sure. So I think as you're planning ahead, there's certainly no harm in getting involved in some type of research that's not too time intensive. I mean, you're in medical school, you really want to enjoy your time. Soak it up while you can. Focus on doing well in medical school. I don't want people to get bogged down feeling like they need to do research projects, but there certainly are sometimes some low-hanging fruit, easy projects that you can get involved with. You can always email myself, or if you happen to be on service with one of the attendings or the fellows, you can always touch base with them and say, oh, you know, I'm interested in getting involved in a project that I could realistically do with the time I have available. I think as you start planning your transition into residency, that's a key time. So when you think about residencies, if you think you might be interested in GI or any other medicine subspecialty, it's important to go to a residency program where they have those fellowship subspecialties. Even if that's not where you decide ultimately to go into fellowship, that's where you will make a lot of connections that will help promote your application for fellowship. And work a lot with those teams and the staff there and get more research at that time, for sure. So definitely shoot your sights high for residency applications and try going into university programs that have these fellowship programs.
Oh, well, thanks for all that helpful information. So Dr. Palagiri, earlier you had mentioned that your husband is a physician. I myself am a member of a 2 medical student household currently, and I'm just wondering if you have any advice about maintaining a good relationship throughout medical training and then into practice as a physician.
Yeah, it's tough. So try to find something that you both like to do. My husband and I, before we had our son, we like to eat out. We like to eat good food. So that was our treat. Sit down together, have a good meal, and take the time to do that. Was very important. Take vacation. Try to line up your vacations at the same time, and that can be hard to do. So you may need to plan a year in advance when you're going to take a week off. But even if it's a year down the road, just knowing that you have it there to look forward to is very important. So lining up your vacations, find something that you like and do it together. And even just being able to decompress together, I think is therapeutic. You each understand on some level the stressors that the other one is going through. So being able to sit down and share stories over a beer or over coffee or tea is always very nice. And so that's very helpful too. My husband and I, at the end of the day, sometimes we just like to veg out and watch a show and that's enough. But yeah, also spending time just sitting and talking is important, and vacation.
So now that you're, did you say you had a son?
Mm-hmm.
Okay, now that your son's a little older, how do you feel the balance is now? Like, is he old enough to drive on his own?
No, he's actually only 5. So he's older and then he's now in school, in kindergarten. So, I think that part is definitely stressful, managing children. And everyone's situation is a little bit different. If you have family in town, or you have, kind of access to a good, reliable childcare, that's great. But having many layers of backups is always important. So we don't have family in town to help us, and so that was part of the reasons that going part-time really helped us. I didn't want to quit entirely because I really like what I do, and I also wanted to maintain my skills, and so that the way we did it worked out. I've heard other people where both couples end up going part-time, so they're kind of tag teaming together. St. Louis has a lot of great childcare resources, and most cities do, and physicians network together really well in order to help each other out. And so there's a lot of coverage that we do for each other kind of last minute when we have kid problems and things like that. We have layers of backup childcare in place just in case we need it. So that is, it can be a challenge, but it is definitely doable and people do it. But I think kind of recognizing what your priorities are and planning ahead is helpful.
Well, thank you for the advice. As we wrap up here, Dr. Palagiri, do you have any last pieces of advice that you'd like to leave students just about medical training, life, anything along those lines?
Sure. So a few things. One, medical school is an awesome time because right now you are sampling everything. For those of you who are going to be moving into third and fourth year, just do electives that you are interested in. Just because you're interested in them. So you may want to do forensic psychiatry or, another OB elective, neurosurgery, just because this is your one time that you'll get to do those things. And then once you start residency, you'll be heading down your career path and you'll be subspecializing. So just spend some time doing some things that you enjoy that you probably never get to do again. So, it's fun. And third year, you get to deliver babies, and I will probably never do that again, but it's fun, fun stuff to do. So enjoy the time. Try to keep the well-rounded aspect of yourself that got you into medical school. Try to maintain that. It's easy to get tunnel vision and just start thinking about medicine and not reading anything else. So definitely take the time to kind of step away periodically and remember the things you like to do, because it certainly can get very stressful. And that's good to take that time, certainly. Yeah. Anything else?
Well, if we don't have any more questions from the students, thank you so much, Dr. Palagiri, for taking the time out to talk to us. All these insights have been so great. And thank you to everyone else who tuned in. This has been Physician Pathways.
Oh, thank you. And you can always email me, if you have questions as you're planning your schedules and residency and all that down the road. So